Medical chapter. The standards in this chapter define the medical staff leaders' roles and responsibilities in credentialing, privileging, bylaws development, committees, departments management, patient care, as well as performance improvement. In order to score the MD standards, there are different variety of activities. The MD chapters necessitate to score 114 scorable standards from document review, 96 from closed medical record review, 40 from observation, 76 staff interview, 105 from document evidence, 112 open medical record review, and from personal file review, 103. MD scorable per chapter. Basically, the medical standards are scorable from variable chapters, but the majority from the provision of care, plus other chapters such as medical staff, leadership, quality, operating room, critical care, whether it is adult, pediatric, neonatal, or coronary, labor and delivery, hemodialysis, burn care, oncology, radiotherapy, as well as few standards from the medication management, management information, facility management and safety. It's very important to know that there are 8 essential safety requirements scorable in the MD chapter. HR 5, the hospital has a process of proper credentialing of staff members licensed to provide patient care. MS 7, medical staff members have current delineated clinical privileges. PC 25, policies and procedures guide the handling, use and administration of blood and blood products. PC 26, patients at risk for developing venous thromboembolism are identified and managed. QM 17, the hospital has a process to ensure correct identification of patient. QM 18, the hospital has a process to prevent wrong patient, wrong site, and wrong surgery procedure. Anesthesia 2, anesthesia staff members have the appropriate qualifications. Anesthesia 15, qualified staff perform moderate and deep sedation analgesia. MD chapter modules is composed of 5 modules. Each module takes 20 to 30 minutes and composed of interrelated group of standards. The 5 modules are the medical staff, medical committees, patient care, specialized patient care, medical departments. The medical staff module, which is module number 1, the topics discussed during this module: the medical staff bylaws, medical director and head of medical departments, medical staff, credentialing and privileging, primary source of verification, performance of the medical staff, involvement of medical staff in hospital-wide quality improvement, staffing plan. The medical module 2 discusses the essential medical committees, and those are the Medical Executive Committee, Departmental Morbidity and Mortality Committee, Hospital Mortality and Morbidity Committee, Medical Records Review Committee, Utilization Review Committee, Operating Room Committee, as well as Cardiopulmonary Resuscitation Committee. The third medical module, it's related to the patient care, and it will cover patient screening before accepted for care in the hospital, uniform standard of care, initial assessment of patients, medical assessment, accessibility to care and services, overall care management of inpatients, plan of care, invasive procedures, physician orders, consultations, transfer of patient between hospital units and to other organizations. The fourth module of medical chapters, specialized patient care, and it covers clinical practice guidelines, pathways and protocols, reporting of critical results, organ donation, handover policy, international patient safety goals, venous thromboembolism, patients requiring cardiopulmonary resuscitation, patients with deteriorating consciousness, care of vulnerable dependent patients. The fifth module is related to the medical departments, such as critical care units, respiratory therapy, physical therapy, oncology and radiotherapy, labor and delivery, burn care, radiology services, emergency care, anesthesia care, operating room, psychiatry care service, dental care. Module 4 of MD chapters, tackling standards of patient care. In spite of hospital variations concerning their scope of service, optimum patient care should be provided based on studied planning, good coordination, and effective communication to assure the best possible outcome. Standards aim continuity of care, patient assessment to document care process, and collaborative process provided by multiple healthcare providers, while promoting coordinated care, particularly in referred, transferred, or discharged patients. The main outlines of this presentation are access to care, medical assessment and reassessment, inpatient care, transfer of patient, discharge process, and continuity of care. Over the past 2 decades, patient-centered care has become internationally recognized as a dimension of the broader concept of high-quality health care. Rupp and Seddon identify the following common concepts and definitions of patient-centered care: eliciting and respecting patient preference, informing and involving patient, engaging patient in care process, treating patient with dignity, designing care process to suit patient needs, ready access to health information, continuity of care. Crossing the Quality Chasm by the Institute of Medicine defined a good quality care in 2001 as safe, effective, patient-centered, timely, efficient, equitable. Goodrich and Cornwell have identified the core elements of patient care framework as education and shared knowledge, involvement of family and friends, collaboration and team management, sensitivity to non-medical dimensions of care, respect of patient need, the free flow and accessibility of information. Becker Institute and Harvard School of Medicine research on 1993 identified 8 dimensions of patient-centered care through the patient eyes: respect of patient preference and values, emotional support, physical comfort, information, communication and education, continuity and transition, coordination of care, involvement of family and friends, access to care. In more details, the outline of this presentation discussing the following aspects under the access of care, accessibility to care and service, uniform standard of care, patient screening before accepted for care in hospital, as well as the standards for medical assessment and reassessment, The standards related to inpatient care will be tackling consultations, plan of care, physician orders, invasive procedures, transfer of patient discharge process and continuity of care. The standards will cover transfer patient between hospital units and other hospitals, discharge process and continuity of care after discharge or referral. Access to care. Accessibility to care and service. Two standards covering this important aspect. Provision of care 1 and 5. PC1, the hospital provides patients with information on care and services provided. PC5, the hospital ensures easy accessibility to care and services. 3 substandards under the PC1. The hospital clearly defines the service. It should be in appropriate format and language. Patients should be provided with information how to access its services. The standard intent, hospitals must make sure to define in a clear method of their scope of service, and it should be available to patients, their families, as well as the wider community in appropriate format and language. Information must include the way patients can access the hospital services. Substandards can be scored by looking into the document reviews, document evidence, as well as interview to cover the 3 substandards. Substandards of PC5 clearly discusses the physical accessibility of services to all patients, efficient appointment system, minimizing language barrier by a clear process created by the hospital, as well as ensuring effective communication with patient having special communication needs. Surgical intent. The hospital ensures easy physical accessibility of all hospital departments to all patients, and identify any barriers and implement the process to eliminate those barriers, such as adopting appointment system and minimizing language barriers. Substandards of PC5 can be evaluated and scored by the following activities: unit visit and staff interview. Uniform standard of care. 2 standards, PC3 and PC4, covers this uniform standard of care. The hospital has a consistent process for registration and admission of patient. The hospital ensures uniform standard of care. There are 6 substandards under PC3 that clearly discusses the necessity of available policy and procedures that defines the process of elective admission and day procedure, admission of emergency patient, the use of registration of outpatient, the admission when no bed available, and the process where observation of patient is needed in emergency room. Staff members should be aware of and implement a consistent process for registration and admission of patients in different service settings. Basically, the standard intent states clearly that the process for registration and admission to the hospital must be standardized, and the following should be considered: registering outpatient, registering inpatient, admission to day procedure, admission directly from emergency service, and the process of holding patient for observation in emergency room. PC3 could be evaluated and scored by the surveyor through the following activities: document review, staff interview, and combination of both. There are two substandards under PC4. The first one, PC 4.1, ensures that the patient receives the same standard of care across all hospital settings. The patient receives the same standard of care all the times, the same standard of care regardless race, gender, or religion. Patient receives the same standard of care regardless their ability to pay or source of payment. PC 4.2, patient care service are in accordance with the professional standards and applicable laws and regulations. Standard intent, patient care must be standardized, uniform, professional, and matching the laws and regulation in all hospital departments at all times, regardless of race, gender, and religion, and regardless of patient ability to pay. PC4 scored through observation and staff interview. Patient screening before accepted for patient care in hospital. PC2, patients are screened before accepted for care in hospital. The four substandards under PC2 discuss clearly that the policy needs to define the screening method. It should identify the patient needs and match it with the hospital mission and available resources. In outpatient, the screening should be performed before registration. In emergency room, it should be performed during the triage process before deciding for admission to the surgical intent. Matching patient needs with the hospital scope of service depend on obtaining information on patient needs and conditions through screening in the outpatient setting before registration. In the emergency room, where triage criteria, visual evaluation, and physical examination are applied. PC2 are evaluated by using the following activities: document review, staff interview, and observation. Medical assessment and reassessment is one of the important aspects in patient care. 9 standards are covering this aspect. Substandards covering PC6. The hospital has a systematic process for initial assessment of patients, and this should be covered at all care settings for all categories of patients by all disciplines, and should be done and performed by qualified, by licensed, certified, and experienced healthcare provider. Initial assessment aims to identify the general patient's medical and nursing needs and a provisional diagnosis so that care and treatment can be initiated. Intent and effective patient assessment is an ongoing dynamic process, results in decisions about patients' treatment needs. The scope of assessment, policy, and procedure must address the following: all hospital settings, all patient categories, all disciplines, healthcare workers. Only qualified individuals conduct the assessment, the main aim of the assessment. PC6 is scored by using the following activities: document review, closed medical record, and open medical record. PC7, a policy should be available to define the criteria for process of screening patient for pain, functional limitations including the risk of fall and malnutrition, and should be developed by a qualified individual. comprehensive pain assessment should be addressed, as well as functional assessment and nutritional assessment. Standard intent: the patient's initial assessment should include screening for pain, functional needs, and nutritional needs. And if the screen is positive, should be referred to the appropriate specialty for a full assessment. For example, a patient risk of nutritional needs are further assessed by a dietitian. PC7 is scored by the surveyor by the following activities: staff interview, document review, as well as open medical record. PC8 clearly states the initial assessment includes the need for discharge planning. The 3 substandards shows that the hospital has a criteria to identify patients requiring discharge planning with a proposed discharge date set soon after admission. Staff members are aware of the discharge planning process, particularly for common cases with predictable outcome. The hospital must have criteria to identify patients requiring discharge planning before or upon admission. Discharge date should be included in this discharge planning, and the staff should be aware of this stated criteria. Activities needed to score the discharge planning: standard, document review, open medical record, and staff interview. PC9 initial assessment of patients is completed and documented in the medical record on a timely manner. 6 substandards covering this standard, which states clearly that there should be a time frame for completing medical and nursing assessment, should be completed and documented within 24 hours of admission for routine elective cases, and should be should be completed earlier than that whenever it's indicated, such as an emergency case. Assessment should be completed within 30 days prior to admission, and if it is more than 30 days, should be repeated. Medical and nursing assessment are completed and documented in all patients prior to surgery, anesthesia, or invasive procedure. Surgical intent: the patient's medical and nursing needs are identified from initial assessment, and it should be completed within the first 24 hours after admission for elective routine admissions, and earlier than that when the patient condition is needed, as in emergency cases. Assessment prior to admission should be in the previous 30 days, and if it is more than 30 days, it should be repeated, because this reflects the significant changes in the patient condition since the assessment are noted at admission. Closed medical records and open medical records are the appropriate tool or activity to assess the substandards in PC9. PC10. Medical assessment is completed and documented for each patient, and the substandards under PC9 clearly defines the required parameters that included in the assessment of each patient, such as main complaint, detailed of present illness, system interview, past history, including previous admissions and surgeries, allergies, family history, psychosocial history, economic history, pain history, diagnostic tests, physical status and functionality, need for additional or specialized assessment indicated by the patient, need for discharge planning, provisional diagnosis. The most responsible physician ensures all patients under his care have completed medical assessment with all diagnostic tests and referrals as required, and it should be performed by the most responsible physician or a member of his team who is qualified, certified, and experienced. Diagnostic tests are available as indicated, and diagnostic tests are appropriately and timely ordered. Medical assessment is documented in the patient's medical record. The patient's initial medical assessment must cover all essential basic elements such as those mentioned in the substandards we mentioned earlier. In addition, an appropriately ordered diagnostic test, for example, laboratory or radiological, must be documented and available in the patient's file. It is the responsibility of the qualified licensed physician under the supervision of the most responsible physician. Closed medical records as well as open medical records are the appropriate tools to assess the PC-10 and its substandards. 12 additional and specialized assessments are performed for identified patient groups. Specialized assessment includes patients with dental, hearing, eye, or speech defects. When additional or specialized assessments are required, they are completed and documented in the patient's medical record. Gathered at the initial medical and/or nursing assessment may indicate that they needs further or more in-depth assessment such as dental, hearing, vision, and/or specialized additional assessment in some categories of patients. These assessments must be completed and documented in patients' files. Open medical record is the appropriate activity or tool to evaluate PC-12. 17. Patients are reassessed to ensure effectiveness of care plans. All patients are reassessed at appropriate intervals to determine response of treatment, compliance with treatment, complications and side effects, plan of continued treatment, or completion of treatment. Medical assessment must be performed at least once daily, including weekends and holidays, and in response to any significant changes in the patient condition. Reassessment by all patients' healthcare practitioner is the key of understanding whether care decisions are appropriate and effective. Patients are reassessed throughout the care process at intervals based on their needs and plan of care. An acute care patient should be assessed at least daily, including weekends and when there has been significant changes in the patient condition. Reassessment are conducted as a result of and entered in the patient medical record at regular intervals daily by the physician for acute care based on the patient condition and in response to significant changes in the patient condition. If the patient diagnosis has changed and care needs require revised planning, and to determine if medication and other treatment has been successful and patient can be transferred or discharged. Closed and open medical records are the appropriate activities to assess PC-17. Inpatient care includes consultations, plan of care, physician orders, and invasive procedures. PC-36, the hospital has an effective process for consultation between specialty services. PC-36 defines clearly the role of consulting and consulted physician in details of documenting the consultation and filling the form of consultation, indicating clearly the date and the time, the name of the consulted and the consulting physician, the recommendations and the need of transfer of patient under a new consultant. The consultant physician approves and follows up the implementation of plan of care as set by the consultant physician. ER13, which is related to the consultation for the emergency department. It contains 3 substandards that defines a clear policy and procedure that regulates the consultation request coming from emergency department, level of consultation identified including immediate, level consultant physician, and the way of communication are included. From another specialty, hospital must design an effective consultation process with a well-designed consultation request form that clearly and timely completed by both consulting and consultant physician. Medical record is the activity to evaluate and score PC36. Emergency department must have a process for requesting other specialties to assist the patient when needed. Evidence, closed medical records are activities to evaluate and score ER13. 3 standards covers the plan of care. PC16, a comprehensive plan of care developed collaboratively and documented for each patient. PC17, patients are reassessed to ensure effectiveness of care of plan. PC20, provision of care continued, integrated, and coordinated. There are 9 substandards under PC16 that shows how to develop comprehensive plan of care. Plan of care should be developed collaboratively between healthcare team, patient and family. The plan of care is based on assessment findings and aim to meet patient's need. Patient and family are involved in developing plan of care. The plan of care contains measurable goals and desired outcomes. It's completed within 24 hours of admission or even earlier. It's completed whenever possible before the end of the shift. By nursing, the plan of care is reviewed by most responsible physician on daily basis. It is modified as appropriate upon significant changes in the patient condition. It includes provisional date of discharge within 24 hours of admission. The plan of care is documented in the patient medical record. The plan of care identifies a set of actions that the healthcare team will implement to resolve and support the diagnosis identified by assessment. The overall goal of plan of care is to achieve optimal clinical outcomes. It should be developed collaboratively and use data from initial assessment and from periodic assessment. Patient and family are involved. It should be developed within 24 hours of admission as an inpatient and documented in the patient medical record. Plan of care for a patient must be related to his identified needs, and it contains measurable goals. Those goals should be observable, achievable, target related to patients, realistic, specific to patient, and time-based. Open medical record is the appropriate activity to evaluate and to score PC16. Patients are reassessed to ensure effectiveness of care plan. Patients are reassessed at appropriate intervals to determine response to treatment, compliance with the treatment, complications and side effects, plan for continued treatment or completion of treatment. Reassessment by all patients' healthcare practitioners is the key to understand whether care decisions are appropriate and effective. Patients are reassessed throughout the care process at intervals based on their needs noted in the patient record. A physician assesses the acute care patient at least daily, including weekends and when there has been a significant change. Closed as well as open medical records are the appropriate activities to assess PC17 for reassessment of patient. PC20 provision of care is continued, integrated, and coordinated. There are 3 substandards under PC20. Information about patient's care and response to treatment is shared between medical nursing and other care providers. For example, during the patient rounds, multidisciplinary teams, case management for patients requiring complex care. Patient's medical record is available to all authorized care providers. Information about patient care and progress is exchanged during change of shift, reporting handover, and between shift or during transfer and referral between healthcare providers. Continuity of care is enhanced when all patient care providers have the information needed from the patient's current and past medical experience to help in decision making. All information should be recorded in the patient record and should be available during inpatient care or for outpatient visits to all healthcare providers related to the patient care. Open medical record document evidence are activities to evaluate and assess the PC20 standard. Physician orders. PC21 physician orders are documented in a consistent location within the medical record. There is a physician order form where physicians document all orders related to the patient care. Only physicians are allowed to write in the physician order form. Physician orders include medications and non-medication orders. All orders are acknowledged by the nurse in charge of the patient, dated and timed. Physician orders must be documented in the patient record, such as orders for laboratory testing, administration of medication, specific nursing care instruction, type of nutrition therapy, need for rehabilitation, and so on. Such orders are ordered by individuals qualified to do so. Such orders must be easily accessible if they are to be acted on a timely manner. Locating orders on a physician order form. Open medical records are the activities to assess PC21. Responsibilities and accountabilities. PC15. In hospital, patients have their overall care managed and coordinated by one qualified physician. PC15 get 5 substandards that shows that the most responsible physician, a qualified physician, is responsible for the overall care rendered to the patient. The most responsible physician must have the privilege to admit the patient. The most responsible physician carries the overall responsibility and accountability for the outcome of care provided to the patient. And he is the principal care plan and coordinates when required for additional plans of other healthcare providers. Transfer of patient responsibility from one physician to another guided by the hospital policy and documented in the patient medical record. Each patient admitted to the hospital must be under the care of one physician called the MRB, or the most responsible physician, who is privileged to deliver required care to the patient and will be accountable for outcome of care through developing an appropriate care plan and coordinated with other care providers if additional care required. Hospital must have a policy to guide patient care transfer from one physician to other physician to ensure proper and quantum of care provided to patient. Open medical record, staff interview, and document evidence are activities required to assess, to score the PC15. Invasive procedures. The hospital ensures uniform patient care process during invasive interventions. The hospital ensures uniform patient care process during invasive intervention, and this is covered by 3 substandards. Hospital implements a policy for assessment and management of patients undergoing invasive procedures. The policy defines all essential requirements that must be documented in the patient medical record, such as the date, time of procedure, name, designation of and signature of the physician performing the procedure, and the names of assistants, locating the procedure, the nature of indication of a procedure, any anesthesia or analgesia required, including the dosage and type, patient monitoring, procedure outcome, complications, laboratory specimens, specific post-procedures. The third substandards shows clearly that invasive procedures are documented in patient's medical record or in appropriate form as per policy. Because invasive intervention carries a high level of risk, the hospital must develop a policy to guide the process from planning till the end of the procedure, including documentation of the procedure and monitoring of the patient status, including elements mentioned earlier in the substandards. Open medical records are the appropriate activity or tool to assess PC-19 for related to invasive intervention implementation. Transfer of patient discharge process and continuity of care, transfer patient between hospital units and to other hospital, and discharge process and continuity of care after discharge or referral. There are 4 standards related to the transfer patients between hospital units and to other hospitals. The first standard for transfer of patient between hospital units and to other hospitals, policy and procedure guides the transfer of patients between hospital units. There are 5 substandards that states clearly that the most responsible physician assess the need for transfer and matches the condition of the patient with admission criteria of the unit. Verbal or written agreement as received from receiving unit is documented in the patient medical record, including the name of receiving physician. The MRB assess the transfer requirement, both staff and equipment. Summary of the patient medical and nursing assessment finding, including reason of transfer, diagnosis, clinical findings, and current medications, is available in the medical record. Before transfer, the physician and the nurse at the receiving unit assess the patient at arrival to ensure safe and smooth handover. As patients move through the hospital from departments and services to another, many different healthcare practitioners may be involving in providing care. For the purpose of continuity of care, the hospital must develop a process of communication to facilitate smooth handover of patient care between hospital units. Both medical and nursing staff must receive the patient from the transferring unit and reassess the patient to ensure safe and smooth handover. Closed medical record is the activity used to assess the policy and procedure guides to transfer patient between hospital and units. The hospital has a safe and efficient process for initiating transfer to another organization. There are 6 substandards that regulates the transfer of patient from the hospital to another hospital. Policy and procedure guides the transfer of patient to another organization. Transfer is based on the patient healthcare need for continuity of care and the resources available for both referring and receiving organization. The MRB determines the need for transfer, the most suitable time for transfer, resources required during the transfer, and whether the receiving organization can meet the patient health and supportive needs. There are written transfer criteria for staff to follow. There is a written acceptance transfer for responsibility for patient care by receiving providers and organization. The hospital communicates with all potential receiving organizations, and necessary arrangements are made whenever applicable. Transferring patient to an outside organization is based on the patient's status and need for continuing healthcare services. Transfer may be in response to a patient need for specialized consultation and treatment, urgent services, or less intensive services such as subacute care or long-term rehabilitation. Criteria help to identify when a transfer is necessary in order to ensure the patient's needs are met. PC39 is scored through the use of the appropriate activities, document evidence, close medical record. 40. The hospital ensures safe transportation of patient during transfer to other organization. The most responsible physician assess the transportation needs of the patient according to his condition. Transportation needs of the patient are communicated to the relevant staff. The transportation is provided promptly and safely in emergency cases, for example, trauma or cardiac emergency. The most responsible physician ensures that all patient health needs during the transportation are met. Transferring a patient directly to another healthcare organization may be a brief process with alert and talking patient. It may be involved moving a comatose patient. It requires monitoring. Thus, the condition and the status of the patient determines the qualification of the staff member monitoring the patient. Our aim here is patients to be transferred safely. Such process addresses how responsible is the transferred between practitioner and setting, criteria for when transfer is necessary to meet the patient needs, who is responsible for the patient during the transfer. Close medical records and staff interviews are the activity to evaluate and to score the PC40, transfer to another organization. PC41, the receiving organization of a transferred patient receives the necessary information for continuity of care. Summary of the patient condition, for example, discharge summary, is sent with the patient to the receiving organization, and the summary should include reason of patient admission, patient diagnosis, brief summary of hospitalization and service provided, medication list at the time of the last dose given, patient condition and physical status at the time of transfer, rationale for transfer, results of the patient's diagnostic investigation, laboratory, and radiology. To ensure continuity of care, patient information is transferred with the patient. A copy of the discharge summary or other written clinical summary is provided to the receiving organization with the patient. The summary includes the patient clinical condition or status, the procedure and other interventions provided, and the patient's continuing needs. Close medical records is the activity to evaluate and score PC41. Two standards, PC38 and PC42, required to be fulfilled for efficient discharge process and continuity of care after discharge or referral. PC38, the hospital has an efficient discharge process. 9 substandards, including that the patient and family are involved in the discharge process with clear follow-up instructions. Discharge is based on patient condition and relevant policies or criteria. Patient needs after discharge are assessed as early in the care process as possible. The discharge process identifies the post-service needs and support continuity of care after discharge. The post-service needs are communicated to the relevant staff members. Staff members ensure coordination with the various departments involved in the discharge process. Whenever required, staff members ensure coordination with outside organization and post-service providers as appropriate to the patient needs. Staff members ensures that all patient needs are met prior to discharge. Policies and procedure guide transfer of patient to other organizations. Discharging a patient to a healthcare practitioner outside the hospital, another care setting, home or family based on the patient's health status and need for continuity of care of services. The patient, physician, or individual responsible for his or her care must determine the readiness of the discharge based on the policies and relevant criteria or indications of referral and discharge established by the hospital. Criteria must be used to indicate when the patient is ready for discharge. Continuing needs may mean referral to medical specialties in rehabilitation or even preventive health needs coordinated in home by the family. An organized process is required to ensure that any continuing needs are met by appropriate healthcare practitioner or outside organization. The process includes referring patients to sources of care outside the region when required. When indicated, the hospital begins to plan for the continuing need as early in the care process as possible. Close medical records and document evidence are necessary activity to evaluate the compliance to PC 38. PC 42, the hospital ensures the continuity of care after discharge or referral. Whenever required, follow-up appointments are arranged for the patient. Hospital provides discharge summary for all inpatients upon discharge. A copy of discharge summary is kept in the patient medical record. A copy of discharge summary is given to the patient. As appropriate, a copy of discharge summary is provided to the healthcare provider responsible for the patient continuing or follow-up care. The discharge summary is complete and typewritten. Referring a patient to another organization, the referring hospital must determine if the receiving organization provides services to meet the patient needs and has the capacity to receive the patient. This determination is usually made well in advance, and the willingness to receive patient and the transfer condition are described in formal and informal affiliation or agreement. This advance determination ensuring continuity of care and that patient of care needs will be met. Transfer may occur to other sources of specialized treatment or services without formal or informal transfer agreements. Close medical records and staff interview are the activities used to evaluate and score PC 42.